Hi everybody, good morning. My name is Sophie and I'm presenting my project that I've been working on with the Schmidt Lab on evaluating the relationship between uric acid and podocyte health in patients with biopsy-confirmed kidney disease. All right, so for a bit of background, your kidneys are these two organs that sit in the back of your body, and they're responsible for not only filtering waste products out of your blood, but ensuring that things like vitamins and minerals and large proteins remain within the bloodstream and do not end up in the urine. Now, this can be a problem for patients with something called chronic kidney disease, which is a loss of kidney function that worsens over time. Chronic kidney disease is very serious. Patients typically don't get better, they only continue to get worse, and oftentimes they require dialysis or a kidney transplant. Because of this, CKD is broken down into many stages. You can see in stages 1 and 2, patients often don't even know that they have kidney disease because there's not really any biomarkers for bad kidney function. However, around stage 3, we can start to see severe impairment, and this is around when CKD would be picked up by a person's physician. Stage 5 is very severe. That's kidney failure, where your kidneys are not filtering anything at all. Now, we mark this by something called the estimated glomerular filtration rate, which you can see on the left of this diagram. What this is this is the volume of blood being filtered by your kidneys per minute. So, for a larger eGFR, such as 90, the person doesn't have stage CKD. They either just have stage 1 or they're completely fine. But when that estimated glomerular filtration rate drops below 15, they're in kidney failure and immediate action needs to be taken to preserve kidney function. So what my lab specifically looks at is a specific type of cell known as podocytes. These are epithelial cells that line the entrance to your kidney, so the site of initial filtration. What's unique about podocytes is that their cell bodies float in the urinary space while they remain attached to the capillaries via foot processes. These foot processes literally look like feet coming off of the cell, and they connect to each other and to the capillary to hold everything in place. This is really important because podocytes can't regenerate, and so while a healthy person has enough podocytes to remain and retain kidney function for a long time, with a person who has CKD, their kidney cells are being injured and they're dying off. And in order to respond to that, those podocytes are going to widen and they're going to cover more area, leading to a very specific type of injury known as foot process effacement. So when those foot processes, which normally are same size, as you can see in the top diagram, and they have these spaces between them that allow for molecules to pass through, when podocytes die off, those foot processes become effaced, and they separate out, and that gap becomes wider. So while healthy foot processes are able to stop larger proteins from filtering into the urine due to their small size and charge-specific barriers, when effacement occurs, larger proteins are then able to sneak into the urine, which can lead to problems, right? We don't want things that we want to stay in our blood being excreted in the body. This is an example of foot process effacement in actual cells. As you can see in the top picture, you can see each of those little bumps is a foot process, and they're uniform in size, they have even space between them. This person's likely not having a lot of protein in their urine. However, as we progress down the image, you can see the foot processes become more and more effaced until you can't even distinguish them from the capillaries that they're attached to. So what my project was on was evaluating the relationship between uric acid and foot process effacement. Uric acid is an end product of DNA degradation. We can't break it down any further, and what's interesting about it is that it typically gets excreted through the urine. However, in patients with kidney disease, we can sometimes see that it is retained in the blood. This is interesting because uric acid is pro- and anti-inflammatory. It protects red blood cells from oxidative radicals, but it also activates things like the renin-angiotensin-aldosterone cycle, which creates inflammation that can damage kidneys through scarring. And there's been inconclusive research so far about the impact of urate-lowering therapies on kidney function and chronic kidney disease progression. So what was I looking for? I was looking for an association between uric acid in the blood and greater kidney dysfunction and damage. I was also looking for a correlation between severe foot process effacement as a way to determine if uric acid is associated with podocyte damage. The way I did this is I used data from the Boston Kidney Biopsy cohort study. This is a prospective cohort study of 3 tertiary care hospitals in Boston where we had access to not only biopsies, but blood and urine samples from each patient. From 519 patients, we extracted foot process effacement data from pathologist-adjudicated imaging reports. And we used electron microscopy images like this one to determine how effaced the podocytes were. From there, we were able to evaluate kidney function using both the blood and urine samples by using the estimated glomerular filtration rate and a metric called proteinuria that I'll speak about in a minute. Finally, we assayed the blood for uric acid so that we could know if patients who had high levels of uric acid in their blood were displaying these signs of kidney damage. So, one of the big things that we were looking for, in addition to that estimated glomerular filtration rate, is proteinuria. As I mentioned before, when foot processes are effaced, high levels of larger proteins are able to escape into the urine due to the disruption of that size and charge-based barrier. Because really the only thing that causes proteinuria is kidney damage, it's an indicator for CKD, and we can use it to determine if a person has high levels of kidney impairment. Specifically, what we were looking for is the ratio of albumin, a blood carrier protein that typically is not excreted into the urine, and creatinine, a waste product from muscle metabolism that is kept in constant ratios in our blood. When the ratio to albumin was much higher than the ratio of creatinine, it was able to determine that the person had worse kidney function and was showing something called proteinuria. So, what were we able to find out? Well, critically, we were able to see that there was a significant association between high levels of kidney damage and high levels of uric acid. So, in that first graph on the left, you can see that the estimated glomerular filtration rate, which is the rate of blood passing through the kidneys per minute, was lower for people who had higher levels of serum uric acid. So, higher levels of uric acid in the blood, worse kidney function. This was echoed by the proteinuria results. For patients who had higher levels of protein in their urine, they also had higher levels of serum uric acid in their blood. So overall, we saw a correlation between high levels of serum uric acid, worse kidney function. But what about foot process effacement? Well, we saw the same thing here. We categorized foot process effacement for all the patients in our study into 4 categories: none, mild, moderate, and severe. I worked with a pathologist to make sure that these were accurate, and then we were able to compare it to the amount of uric acid that was in their blood. And that's what that line is on the screen. You can see that for patients who had higher levels of serum uric acid, they were more likely to also have severe foot process effacement based on their biopsy results. Now, we had a far more mild foot process effacement category than we did for any of the other categories. So for other analyses, we were able to lump in the none and mild categories together. In conclusion, what we saw was that higher levels of uric acid were associated with a lower estimated glomerular filtration rate and higher levels of protein in the urine, indicating that there is a correlation between uric acid in the blood and severe foot process effacement. We also saw a potential link between podocyte injury in the form of foot process effacement and hyperuricemia. So what does this mean? It means that we need additional studies. I like to refer to this as stepping stone research. It sort of helps us figure out that in the future that maybe we should be re-looking at urate lowering therapies or therapies that lower uric acid in the blood as a way to help prevent podocyte loss in CKD patients and prevent progression of CKD. Thank you very much. Do you have any questions?
So for a urate lowering therapy, how does that work? Do you take the blood and filter it?
No, so that's dialysis. Urate lowering therapies right now look like 2 different drugs, allopurinol and febuxostat. They have pretty heavy side effects, which is why they're sort of a hard area of study. And the way they work is by inhibiting an enzyme that leads to the creation of uric acid. Yes?
Out of curiosity, how do you prevent all these kidney issues in the future? Like, how do you prevent them from happening in the first place, if any?
Sometimes you can, sometimes you can't. Things like alcoholism will contribute to kidney damage. There are other conditions. Heart disease typically contributes to kidney damage. So if you have a heart disease that gets caught early and managed, you can prevent that from impacting your kidneys. But also, sometimes it's genetic. Sometimes you just have bad luck. There are all these different things that can cause kidney damage.
What drove you to do this research?
I've been working in the Schmidt lab and then also in the Whitecar lab, another nephrology lab at BMC, for 2.5 years now. And so I started there as a sophomore and really just grew to love it and decided to do my honors project there.
Great work, great presentation. So you've been working here for a while. Are you guys publishing this, or have you published any
We're
work?
talking about doing a research letter with it. There's another paper that includes the data that I've collected here and a bunch of other information that is coming out of a postdoc. But yeah.
My follow-up question is if you're working with postdocs or PhD students on this?
Not on this specifically.
Okay, so this was your own.
This is, yeah. I work with Dr. Schmidt directly.
With that, thank you very much, Sophia, for your presentation.